Welcome to STI's presentation on the Resource Use Performance category of MIPS. The cost measures that are used in MIPS aim to measure how a particular clinician or group impacts the patient's costs, both directly and indirectly. CMS has aimed to design the program that encourages more consideration of the cost of care associated with patients even after other clinicians become involved. So the measures require that the clinician who are most significantly responsible for their care, as measured by Medicare allowed amounts, assume accountability for it. The first year of MIPS, 2017, the clinician's composite score will be made up of the three performance categories: quality, which will count for 60% of the clinician's composite score; advancing care information, which would be 25% of your score; and the clinical practice improvement activities, which will weigh 15% of the clinician's composite score. The resource use performance category will not be factored in to your composite score in 2017. Starting in the year 2018, the resource use category will count for 10% of your composite score, and it will increase to 30% by the year 2019. The cost measures within the resource use category will compare resources used to treat similar care episodes and clinical condition groups across practices. This performance category is replacing the Value-based Modifier Program, which is sunsetting at the end of 2016. As I mentioned, it will not be factored into your composite score in the year 2017. But these cost measures will be calculated throughout the year 2017 based off of the claims that you have submitted. All cost measures will be adjusted for geographic payment rate and beneficiary risk factors, as well as specialty adjustments. You do need a minimum of 20 to 35 cases in order to be scored on these cost measures. The measures for 2017 are total cost per capita for all attributed beneficiaries, Medicare spending per beneficiary, and the episode-based measures. There are 10 out of the 41 episode-based measures that will be used in 2017. The total per capita cost for all attributed beneficiaries includes payments under both Part A and Part B, but do not include the Medicare payments under Part D for drug expenses. There has been an expansion of primary care services to align with the Medicare Shared Savings Program, which include the new care coordination codes for chronic care management and transitional care management. It is excluding the nursing visits that occur in a skilled nursing facility. There is a two-step attribution process, and this cost measure does require a minimum of 20 cases in order to be scored. Here is a list of the codes associated with this cost measure, and as I mentioned, the transitional care and chronic care management codes are being factored in. The two-step process that takes into account the level of primary care services received, as measured by Medicare allowed charges from final action claims during the performance period, and the provider specialties that perform these services. Only beneficiaries who receive a primary care service during the performance period are considered in attribution. Step 1. A beneficiary is attributed to a TIN in the first step if the beneficiary receives more primary care services from a primary care physician, nurse practitioner, physician assistant, and clinical nurse specialist, in that TIN than in any other TIN. If two TINs tie for the largest share of a beneficiary's primary care services, then the beneficiary is assigned to the TIN that provided primary care services most recently. Step 2. If a beneficiary did not receive a primary care service from any primary care provider, nurse practitioner, physician assistant, or a clinical nurse specialist during the performance period, then the beneficiary is attributed to a TIN in the second step. If the beneficiary received more primary care services from a specialist physician within the TIN than in any other TIN. The Medicare spending per beneficiary measure evaluates solo practitioners and groups on their efficiency and is specialty adjusted to account for their specialty mix. Specifically, this measure assesses the cost to Medicare of services performed during the episode, which comprises the period immediately prior to, during, and following the patient's hospital stay. You do need a minimum of 35 cases in order to be scored on this cost measure. The episode definition includes Medicare Part A and Part B claims with a start date falling between 3 days prior to hospital admission through 30 days post-hospital discharge. An episode includes the 30 days after a hospital discharge in order to emphasize the importance of care transition and care coordination in improving patient care. Attribution. Each episode is attributed to the one TIN responsible for the plurality of Part B carrier services, as measured by Medicare allowed amounts, performed by the clinician during the episode index. In lieu of using the total per capita cost measures for populations with specific conditions that are used for the BBM, MIPS is using the episode-based measures. There are episode-based measures for a variety of conditions and procedures that are high cost, have high variability in resources used, or are for high impact conditions. These measures include Medicare Part A and Part B payments for services determined to be related to the triggering condition or procedure. You do need a minimum of 20 cases in order to be scored on these episode measures. And episode-based measures each have different attribution methodologies. Attributing episodes to the clinician with the highest Part B charge is not necessarily appropriate in all cases, particularly for the procedure episodes. So attribution for the acute condition episode would be attributed to all MIPS eligible clinicians that bill at least 30% of inpatient evaluation and management visits during the initial treatment or trigger event that opened the episode. The E&M visits during the episode's trigger event represents services directly related to the management of the beneficiary's acute condition episode. MIPS eligible clinicians that bill at least 30% of the E&M visits are therefore likely to have been responsible for the oversight of care for the beneficiary during the episode. Attribution for the procedure episode measures. For inpatient, the trigger event is defined as the inpatient stay that triggered the episode plus the day before the admission to the inpatient hospital stay. For outpatient procedural episodes, the trigger event is defined as the day of the triggering claim plus the day before and 2 days after. Or the trigger event is defined as only the day of the triggering claim. Here's a list of the 10 episode-based measures for 2017. Mastectomy, aortic mitral valve surgery, coronary artery bypass graft, hip femur fracture or dislocation, cholecystectomy and common duct exploration, colonoscopy and biopsy, transurethral resection of the prostate, lens and cataract procedures, hip replacement or repair, or knee replacement. We are currently in the comment period of the final rule. Please submit all your comments and concerns by December 19th by 5 p.m. You can submit your comments both electronically or through mail. I would like to note that those who are submitting comments, your comments are made public, so you want to be mindful as to what information you do share. If you do need additional help, please call the QPP Service Center at 1-866-288-8292. They are available Monday through Friday from 8 a.m. to 8 p.m. You can also send your questions to the QPP at cms.hhs.gov. We are encouraging our clients to obtain their QRUR report to see just how well they have done on the quality and cost measures in our current quality programs. You do need to set up an EIDM account prior to obtaining your QRUR. You can go to STI's website under Resource to find the document entitled Guide for Obtaining a New EIDM Account. This document will provide the step-by-step instructions for setting up a new account, and once that is established, you can then request your QRUR. If you do need help setting up your EIDM account, please call the Quality Net Help Desk at 866-288-8912. If you have any questions regarding your QRUR, please contact the Physician Value Help Desk at 888-734-6433. Some key dates to remember. PQRS, meaningful use, and the value-based modifier are all sunsetting at the end of 2016. MIPS does begin January 1st of 2017. All clients who are participating in Medicare's meaningful use need to submit your attestation by February 28th of 2017. And I just want to point out the update for all returning participants, that is stage 2 meaningful use participants, can now report on a continuous 90-day period. You're no longer required to report on the full calendar year. On January 30th, or by June 30th, 2017, any clinicians wishing to use the CMS web interface must register. Your first MIPS feedback report will be issued July 1st of 2017, and you will then obtain your second feedback report in July of 2018. All MIPS performance data must be submitted by March 31st of 2018. And we will begin to see the MIPS payment adjustments start January 1st of 2019. So just some key dates to keep in mind. That concludes our presentation. Thank you for your attendance.